limitation, and physics, depression, and then anxiety, social unconfidence, and other problem, economic problem, high cost medication, job limitation, and family problem needs special support in physical and physics, and other problem can be faced by Parkinson patient. This is the mechanism of the Parkinson patient. In Parkinson disease patient, the factory of the dopamine that we call substantia nigra pars compacta that decrease produce the dopamine. That's why that will be increase the inhibition from the GPI to the VRM, ventral intermediate, and then the stimulation from VRM to cortex will be decreased. That's why the patient can be have a clinical appearance, bradykinesia, rigidity, difficult to walk. There is direct pathway, and we know there's indirect pathway, there's from STN that's also increase the inhibition from GPI to the thalamus. That's why the patient can be more rigid and more bradykinesia and difficulty to do something. And until now, the treatment, no cure available until now to cure the Parkinson. But what we can do improve quality of life of the patient Parkinson, but not cure the Parkinson. How to decrease the symptom? Medication, physiotherapy, psychological intervention, and surgery. That what we want to share now is about deep brain stimulation and stereotactic brain lesioning. How about the medication? Medication L-DOPA, dopamine agonist, anticholinergic, and monoamine oxidase inhibitor. And brain lesioning, we can do the thalamotomy, pallidotomy, subthalamotomy, lesion on pallidothalamic tract in 4LH1. That in the history, we call it campotomy. And DBS, deep brain stimulation, bilateral subthalamic nucleus DBS, and sometimes we perform the bilateral GPI DBS. Depend on the patient. The patient selection is very important to do this surgery. Before 1952, Irving S. Cooper, that's the surgery for Parkinson's disease was pedunculotomy. But in the 1952, accidentally, Cooper made lesion to anterior choroidal artery before pedunculotomy. We know that's anterior choroidal artery that supply the GPI. That's why after that, the neurosurgeon developed to make a lesion in the GPI. After that, this is, I call it from lesioning to modern lesioning. In the 19th century, early stereotactic equipment developed approach to the deep brain center because it is very deep. And then in 1950 until 1960, ablative surgery performed by Irving S. Cooper from anterior choroidal artery ligation. And then after that, pallidotomy and thalamotomy more frequently done. And then the invention of L-DOPA in the 19th and 16th. And then after that, the patient have like adverse effect from L-DOPA, like dyskinesia or rejection from the L-DOPA, allergy and another, especially in dyskinesia and on-off. We know the patient Parkinson have like on-off condition. If the patient get the medication L-DOPA, the patient will be on, can walk and can run. But after off, the patient cannot move anymore. And then in 1985, pallidotomy, they do the pallidotomy again. And then in the late 1980, the DBS was invented by Alim Louis Binabit, introduced DBS in the neurosurgery field. And now the magnetic resonance frequency ultrasound guidance, it is more frequently done too by all of the many neurosurgeons. This is very old stereotactic apparatus. If we look this is very old, the stereotactic apparatus to reach the deep part of the brain to do the pallidotomy. If we look in the left picture, this is the procedure for pedunculotomy, and in the right, this is stereotactic pallidotomy. And at that time, the stereotactic procedure also done using the awake surgery, with awake surgery. We know that medical limitation increase the dose and frequency, increase the cost by the time, because the dose will be increased and frequency of the taking medication will be increased too, and shorter on period. In the first time the patient get the medication, maybe the L-DOPA can make the patient on in six hours, but by the time it will be shorter and shorter, maybe 1 hour, 1 hour or 2 hours. It will be disturb the quality of life of the patient. And then another problem, it is dyskinesia problem. That's why the neurosurgeon have a role to do the surgery for stereotactic surgery for the Parkinson. This is stereotactic brain lesioning. What the advantage of stereotactic brain lesioning? Lower cost, no implant needed, shorter surgical time, no battery replacement. But this is have limitation to one set treatment, but we can do sequentially brain lesioning. How about the recurrency? Recurrency is still questionable. Some patients have the permanent effect, but some patients, because of the progressiveness of the Parkinson, it will be recurrent again. And then we make a permanent lesion using stereotactic brain lesioning. It must be accurate and precise. How about the brain stimulation? It's not new. It make lengthen the on period of the Parkinson, stabilize the movement, decrease the medication dose and frequency, and adjustable. But the DBS have some limitation. High cost, not always covered by insurance. Battery replacement, need battery replacement, increase the infection rate. Sometimes patients have rejection, although the frequency is very rare. And cosmetic problem for the old or young onset Parkinson. And another limitation is implant problem, disconnection of the cable, electrode, shorting connection, lead fracture, battery exposed, and other problem. Kind of the stereotactic brain lesioning in Parkinson disease is some part of the brain we can perform brain lesioning to increase the quality of life. VIM, ventral intermediate of thalamus, VO, ventral of thalamus, subthalamotomy, campotomy, pallidothalamic tract in foral H1 lesion, and pallidotomy. This is management that we use to treat the Parkinson. If we know the patient Parkinson, idiopathic Parkinson, it means the primary Parkinson, not secondary Parkinson, we need to try medication first. If the medication respond, we need to know it is on off or on every day. If the patient have on every day, it means the response of the medication is still very good. We need to continue the medication. No need to do the surgery. But if the patient have respond on and off of the medication, we need to do the intervention like DBS or brain lesioning, pallidotomy, subthalamotomy, or PTT lesion. But if the patient medication with L-DOPA is unresponsive, we need to worry about is this Parkinson primary or it is a secondary, because the secondary Parkinson didn't have good result to surgery. This is L-DOPA. Usually a patient with L-DOPA responsiveness like this, it is a good candidate for surgery. It means the difference between on and off, it's very, very different. The patient in the off condition cannot walk, but after on condition, 1 hour after take medication, the patient can run. But if the difference between on and off not so different, it's not very good candidate for surgery. This is the sample like this. Sorry, this is before take medication, and in the right video, it is after 1 hour after L-DOPA. It means this patient have good response to L-DOPA. The left video is off, the right video is on, like this. It is very different. It is the sign of this patient with on-off. It is the sign of primary Parkinson. It's good candidate for surgery. Yeah. How about the tremor? The tremor is little bit different. Yeah? We still need to take the medication first, but if unrespond, we do the thalamotomy. But if respond, continue the medication. We need to screening other etiology, of course, thyroid disease, drug-induced tremor, and another degenerative disease. Yeah? It is a little bit different with Parkinson. How about the contraindication? Mental disorder, unresponsive with levodopa, severe brain atrophy like secondary Parkinsonism, more than 80 years old. It is, we look the condition of the patient. The case that the oldest case we do here is 81, maybe in another center, maybe more. There is, look the condition of the patient. Yeah, different condition of the patient, we can see that this is rationalization of the GPI pallidotomy. Why we do the pallidotomy? To make the patient to improve the bradykinesia and rigidity of the patient. This is the lesion in the internal GP. Internal GP, the function of the internal GP is the inhibition to the thalamic, yeah, to the thalamic. If in the patient Parkinson, it is increased. If we make a lesion in the internal GPI, it will be decrease the inhibition to the thalamus, that the thalamus can more stimulate to the cortex, that the bradykinesia and rigidity will be better. But different for the VRM thalamotomy, yeah, it is the difference between medication rationalization and the VRM thalamotomy. For L-DOPA, it is progenitor dopamine. This increase the dopamine production and decrease the tremor. For dopamine agonist, better dopamine receptor, balance dopamine acetylcholine ratio, and decrease the tremor. And the anticholinergic, it is the function decrease the acetylcholine at blood plasma and have effect of antimuscarinase effect and will be decrease the tremor. But for the surgery via thalamotomy, it decreased the acetylcholine receptor, decrease overstimulation with reverberating system in the VRM, and it can decrease the tremor too. How brain lesioning perform? We perform brain lesioning like this. We use a stereotactic apparatus like this. We make a hole, yeah, 1.4 centimeter, and we need to stimulate first in the like VRM or STN or PTT or GPI. We make a stimulation. Yeah. If it is safe, we can continue to trial lesion 45 degrees Celsius until 30 seconds. And it is, if it is a good response and no adverse effect, we can continue to 70 until 75 degrees Celsius in 30 until 40 seconds. How about the long-term follow-up? Yeah, some journal already mentioned about the long-term follow-up for pallidotomy, 5 years or 10 years. It can increase the motoric improvement, like 89% of motoric show motor improvement in the on-state, and 100% of the motor patient show motor improvement in the off-state. Dyskinesia, how about dyskinesia? Dyskinesia, a reduction from 26% until 50% on the day before surgery, and the less than 25% on the waking day after surgery on long-term follow-up. And activity daily living, 72% patients show improvement in the on-state, and 83% of the patients show improvement in the off-state. This is the pallidotomy. The target is posteroventral GPI, effective for dyskinesia, chorea, general dystonia, and head dystonia, and Parkinson. It is in the last time we do it directly, but now we didn't do anymore directly bilateral pallidotomy. This is the target. If we look this is the GPI in the posteroventrolateral, and this is in the below. We can see the calculation of the XYZ, the 3D coordinate. And in the left side, we can look the GPI2. It is just above the optic tract, the lateral border of optic tract. We do it now subsequentially. Now, for example, if we do now the right GPI pallidotomy, and then until 1 year again, and after the first surgery, we do another lesioning, like PTT lesion of VIM. We avoid now to do the bilateral GPI pallidotomy in one time or in subsequently. This is for the sample. It is the typical Parkinson patient, bradykinesia.
Ya, sekarang putar, Pak.
Bradykinesia, rigidity, difficult to walking, postural imbalance, difficult to turn the body. Yeah, the patient, the quality of movement of the patient very low. It is after surgery. Yeah, it is after surgery. Bilateral pallidotomy is very good. The patient can walk, can run. This condition happen 24 in a day. Yeah, all of the day, patient have a good response. Yeah. And how about thalamotomy? This is a very long-term follow-up for thalamotomy until 10 years and 20 years. Yeah, maybe in the new journal, maybe more from this. Yeah, this is the target for thalamotomy. Yeah, the target of the thalamotomy. It's about 11 to 12 and from the border of the third ventricle wall. Yeah, it is just medial of the cerebrospinal tract, and we make a multiple lesion here, yeah, like this, and the diameter of lesion about 3 until 4 millimeter. This is clinical test during surgery. We need to look, yeah, we use this stereotactic apparatus. After we implant the stereotactic electrode, the tremor was decreased, yeah, but it is still temporary, and then we test and we give the permanent lesion to make more permanent result, and we evaluate the response during surgery. What the problem of the patient, we evaluate during surgery, like this, writing or taking a cup, like that. This is before and after surgery. Yeah, it is during our first stereotactic in 2013 and 14 with Prof. Tyra, like that. Okay. And this is another case for tremor. Yeah. The left video, it is before VIM thalamotomy, and in the right one, it is after surgery. It is the same two. This is before surgery, and this is after surgery. If we look this in the left side, it's still tremor. We need time 1 years again to do the another lesioning. We avoid to do at the same time for the thalamotomy, VIM thalamotomy. Okay, this is another hyperkinetic movement disorder, and the target for dystonia, dyskinesia, choreatic hemibalism, we can target GPI, focal dystonia, ventrooral, tremor, VIM, and zona incerta. Yeah, we can make it lesioning or DBS and get our balance, but it is still controversial until now. PPN, pedunculopontine, I not yet done for that. And Tourette syndrome, thalamus, centromedian, yeah, anteromedian of GPI, and hemifacial spasm, it is another surgery. Accuracy and precision is very important for stereotactic surgery, because if we miss position in the maybe 1 or 2 millimeter, the patient can have the adverse effect for the surgery. Yeah, like this. This is the technique of the surgery. Patient, we give the infusion set of the live saline, yeah, normal saline. Make sure the patient already go to the restroom before prophylaxis antibiotic. MRI, yeah, 1 millimeter thickness, no spacing, no overlapping. We use sequence T1, T2, T2 flare, and SWI, SWI, and can be done with or without frame. Yeah, but in here we do with frame. Why it is very important for imaging? Our target coordinate based on imaging before surgery, because we cannot see the imaging during the surgery. We cannot see the target, I mean. We cannot see, but it is based on the imaging before surgery. Mostly no intraoperative MRI or CT available at surgery room. Yeah. During surgery, clinical test just to confirm we are on the right target. Yeah. And maximum MRI 2 weeks before surgery. Do do not use old MRI. This is the picture before invention of the MRI. Our teacher there in the history, they using the ventriculography. Ventriculography. They can do the thalamotomy. Yeah, they can do the GPI pallidotomy. But with the MRI, I think now will be more accurate targets. It is the video of Professor Narabayasi. At that time, he used the like this, yeah, ventriculography, and manually measure the target from the third ventricle to the VRM. Yeah, it is manually. But now we have like CT scan, we have MRI. We should can do the VRM thalamotomy or pallidotomy. Yeah, like this. Yeah. Requirement, what the requirement of this surgery? One is CT scan with frame and MRI without frame. We can use 1.5 Tesla of MRI or 3 Tesla. 3 Tesla is better. Yeah, CT scan always with frame, volumetric, no gap, no overlap. Yeah, this is 1 millimeter thickness, cover all fiducial, avoid reconstruction imaging. Yeah, and this is the parameter for the CT scan. Maybe for the young neurosurgeon in the area, you can show this in your radiographer to make a good CT scan picture imaging. And this is you must cover all of the fiducial. Yeah, this is the surgery. Yeah, this is before surgery. Yeah, proper fiducial fixation and position. This is the stereotactic. Yeah? This is Inomet ZD at the left side, and the right side it is Lexel. Yeah, this is very important. In stereotactic surgery, every step is very important. Yeah, if we miss one of the step, the accuracy and precision will be have an error, big error in there. Yeah, this is the technique to perform install the stereotactic frame. It should be OM line, orbitometal line like this. MRI, how to do the MRI for the stereotactic surgery without frame, no gap, no overlap, 1 until 2 millimeter thickness, same size in every pixel. This is the procedure for T1, yeah, cover all of the brain. It should cover all of the brain. Yeah, this is T1 parameter adjustment. You can show this to the radiographer. This is T2 flare, sagittal slash, cover all of the brain. Good CST apparent. CST, it means cerebrospinal tract. If we can see the cerebrospinal tract structure with very good imaging, we can have a good target to VRM or other of the structure of the brain. This is T2 flare parameter adjustment for the radiographer. Like this is bad imaging. We cannot use this imaging. Yeah? We cannot use this imaging for the stereotactic because the stereotactic for functional neurosurgery should be very accurate and very precise. It different with tumor or neoplasm. This is the sample for good imaging. Yeah? Good imaging for the T2 flare. We can see this CST in the coronal, yeah, cerebrospinal tract. We can see this is the target for VRM, ventral intermediate. And another imaging is T2, coronal set, not cover all of the brain, 90 degree to ACPC, 90 degree to ACPC, optic tract appear clearly. This is T2 parameter adjustment. Yeah. And co-registration in the stereotactic surgery for Parkinson or dystonia or tremor, it is very important to make a co-registration or fusion between MRI and CT scan. Very important step. The fiducial from the CT, but the target is from MRI. That's why it is very important. Need for double check between imaging. Set the best contrast and brightness to make a good registration. Like this is the co-registration. Yeah, we make co-registration between MRI and CT scan. Yeah, the fiducial in the CT scan, but our target in the MRI. That's why it is very important for the co-registration. Yeah, until we have a good co-registration, we can continue the surgery. But if it is no good registration, we need to re-registration again. Yeah, and like that. This is we check the ventricle, the border of the ventricle like this. We need to check like this. Yeah. Okay. Another tips: 1 until 2 hours before MRI, patient should take Parkinson medicine. Yeah, because if the patient didn't take any medicine for the Parkinson before MRI, the patient will be tremor during MRI. The MRI picture will be very bad like that. If the patient still move, give the patient sedation. Yeah, this is frame installation, like I said before, parallel to ACPC, avoid the frontal sinus. Yeah, this is local and CT scan. Yeah, volumetric, stereotactic software. It is very important. Yeah, MRI, CT fusion. You need to know the ACPC and the target position. Yeah, for VRM we have some technique: coordinate based, structure based, and VRM we have like Goya technique, and we develop one technique to find the VRM. You can use that too. The trajectory should not to the sulcus, no ventricle. Yeah, no ventricle. I mean, avoid the ventricle, and left to left, right to right. Make sure left to left and right to right. Yeah, in the operating theater, this is because the patient in awake. Yeah, in awake surgery, like this position is not so good for the patient. Yeah, the airway will be not good. The airway for this. Communicate with patient. Yeah, ask every patient quiet. Every personnel, I mean every personnel like anesthesiology, like nurse, for quiet, because the patient already nervous about the surgery like that. And sometimes we play instrumental music for make the patient not to worry about that. Yeah, this is total care operating theater. Yeah, operating theater. This is the draping, the incision. Yeah, and now we didn't need to hair shaving. Now without hair shaving now. Yeah, it is the last time with still with shaving, but now without shaving the hair. And make sure the electrode. Yeah, electrode. If we have a good trajectory, we good target, make sure again and double check. Yeah, during the surgery, double or triple is okay. Yeah, make a lesion. This is make a lesion, not too big, not too small. Why? Because if it is too small, the tremor will be recurrence. But if it is too big, it will be make lesion in the CST too, and the patient will be hemiparesis or hemiplegia or dysarthria like this. Yeah, diameter of the lesion of about 3 until 4 millimeter. Yeah, this is the opening. During opening, be careful to the vein. We need to open the dura. Yeah, like this, and make sure we are in the correct target. This is the sample. If we are hit the CST, look the mouth of the patient. Yeah, this is the mouth of the patient during the stimulation. It is spasm, and this is spasm like this. It is not a good position. We need to change the position. Yeah, you look this. This is the pyramidal sign. Yeah? Pyramidal sign. If we stimulate the CST, we need to move our target. Yeah. Yeah, and we need to evaluate what the patient problem. We need to bring their hobby or their activity that cannot done during their Parkinson symptom happen like that. Yeah, this is another evaluation. Yeah, this is the film line technique to find the VRM. Yeah, we already published this. Yeah, in the 2021. Yeah, if how we looking for the VRM, we can connect between the posterior part. Yeah, the tip of the GPA, external GPA, and connect between the left and right. Yeah, if there is a line there, and we need to measure about 1.5 millimeter. Yeah, in that place we can find the VIM. Yeah, you can try this technique to make find the VIM easier. Yeah, easier. Okay, this is VIM. Okay, this is the technique. This is VIM2. Yes. This is the tremor patient. Yeah, before the thalamotomy, and this is the after VIM thalamotomy. Direct effect will be happen during surgery. This is the resume of the all of how we do the surgery, stereotactic surgery. Yeah, we need to prepare the like stereotactic. Yeah, and make like local anesthesia. Sometimes we use lidocaine and naropin. Yeah, ropivacaine. Yeah, to make local anesthesia. Yeah, like this. Yeah, we perform the CT scan, make it parallel to the CT scan like this. Yeah. It's cover all of the fiducial. Yeah, we perform the target. This is the target. Yeah, yeah, we used it Inomet ZT. It is the ground. Yeah, yeah, we make sure the stereotactic apparatus with calibration. Yeah, we always calibrate that to make sure we are on the, we have a good frame. Yeah, we open the dura. Yeah, always give the bone wax in the hole like this. Although there is no bleeding, still have this is RF lesioning, radio frequency lesioning. Yeah, radio frequency lesioning. Yeah, and then if you look this, the CSF, yeah, cerebrospinal fluid will be come out. Make sure not too many CSF come out from the brain, because it can make the brain shifting like that. Yeah. Okay, this is the step we need to evaluate before surgery, and this is after surgery. Yeah. Yeah, before you take out the electrode, please like move the electrode, yeah, like this. Yeah, because sometimes it is sticky to the brain. Yeah, this is if we already done like this. How about the another case? This is like hemibalism. Yeah, the stereotactic surgery can be done for the hemibalism like this too. This is before surgery. This is we have done the right GPI lesion and VIM lesion. This is after surgery. Yeah, before surgery, patient cannot walk. This is after surgery. The patient have a good result with the surgery. And now the last one about the deep brain stimulation, like this. They have like chip here and the cable to stimulate the brain. And usually the target of the DBS is STN, subthalamic nucleus, like this. It is the good placement of the DBS in the subthalamic place. Yeah. If we look in the X-ray, will be like this. Yeah. This is before surgery, the patient. The patient in off period, and this is the off. Yeah, this is the after surgery. Yeah, after bilateral STN DBS. Yeah, like this. The patient can move freely after the surgery. Yeah, like this. Yeah. How about the advantage between the brain lesion and DBS? Yes, the brain lesion is cheaper, DBS more expensive. Brain lesion permanent lesion, DBS adjustable. Brain lesion no device-related problem, but DBS have device-related problem like lead problem, IPG problem sometimes. Brain lesion make a lesion, although it is not too big, but DBS just micro lesion and make stimulation. And brain lesion no have didn't have any psychological problem like DBS. DBS sometimes if it has a psychological problem. Can you imagine if the patient with like 40 years old that implant DBS that's still active, it will be have a psychological problem. And brain lesion have need to do the unilateral one by one sequential, and the contralateral lesion will be done after 1 year after the first surgery, and the DBS can be done directly bilateral. Yeah, informed consent before surgery is very important for the surgery. Yeah, clear informed consent. The surgery not cure the Parkinson, but to control the symptom. Yeah, we need to explain to the patient, explain the every step procedure, patient in full awake. It means we need to collaborate with the patient to make the surgery successful and synchronize between the hope and reality. Yeah, because it's not cure, but control the symptom. After surgery, the patient can mobilization 1 day after surgery. Patient can walk with guidance, medication. Do not directly stop the medication. Try to tapering down. And wound care is 1 week after or 2 weeks after patient evaluation, usually 3 months after. And now the timing when the stereotactic surgery have a best result. It is during the on-off, during the response, the L-DOPA response still good. It is a good timing for the surgery. Or the patient, if the patient have a good response to L-DOPA, but have adverse effect from L-DOPA, it is good timing too for the surgery. But for the Parkinson, like still grade 1, still respond to the L-DOPA in all of the day, it is not yet have indication for surgery, or the patient didn't respond to the L-DOPA again. Yeah, if the patient have not experienced any on-off to L-DOPA, it is not good indication for surgery too. It means it is too late for surgery. Now, we frequently do the PTT. Now we do PTT beside the VRM and the GPI, because the PTT for H1 that like Horisawa Sensei do, it is very good response to the patient. Yeah, like this. This is before surgery. This is after surgery. Yeah. This is after surgery, the patient very good. Yeah, bradykinesia decrease, terus rigidity decrease. Yeah, all of the symptom of the patient improve. Yeah, brain lesion and deep brain stimulation has a good result for Parkinson. The result depend on patient diagnosis, treatment decision, target selection, accuracy, and adverse effect avoidance, and hope and reality. Every patient is different, is an art. It is our activity, yeah, for stereotactic and functional workshop. We do that 2013, 2016, and last time, yeah, in the second World Congress of YNS, we have done the brain lesioning and brain lesioning workshop and life surgery. Yeah, many neurosurgeons interesting to do the lesioning workshop. Yeah, and this is last time in the Surabaya, in the second YNS and ACNS World Congress. Thank you to Prof. Kato and all of the member of ACNS to support of the second World Congress of YNS, ACNS. This is our hospital. This is our educational hospital here in the Sutomo Hospital. It's our university, Airlangga University. This is our private hospital, National Hospital, and PSC Hospital. Okay, thank you very much. I hope that's all of the neurosurgeon in every country can do the stereotactic brain lesioning, especially, and stereotactic surgery for Parkinson. Yeah, because with this small hole, the quality of life of the patient will be different, will be improved. The patient will be happy if you select the patient carefully and do the surgery with precise and accurate. Okay, thank you very much. Thank you very much. Thank you.
Thank you so much. It's indeed a very educational lecture, and tell us about every steps of the precaution initiation in DBS. So may I invite Professor Lisang to share the discussion part? Professor?
Okay, thank you. Thank you, Fahmi. Thank you for your wonderful presentation covering from the history and the basic concept of the functional neurosurgery to your clinical practice. And I think
you,
the
Prof. Thank you.
And I think the Parkinson's disease is still very complex syndrome for me. And I understand the tremor dominant Parkinson's disease is a very good candidate of the regioning surgery. And but how can you manage the akinetic rigid Parkinson's disease who does not have the tremor, the only bradykinesia and cause mainly symptoms without tremor, motor symptoms. So can you how can you manage such kind of patients if you use regioning or DBS?
Yeah, thank you, Prof. Marisawa. Thank you, Sensei. Usually we evaluate the patient first. It is the primary Parkinson or the secondary Parkinson. We need to make sure it is the primary Parkinson, not secondary Parkinson, not because of the brain atrophy, not because of the vascular Parkinson, not because of the tumor or other things that can be clinical symptom like Parkinson. We make sure it is a primary Parkinson. If it is respond to L-DOPA, we can manage the medication first. Manage the medication first to make it is a good respond with medication. If the medication not respond, I mean, if the medication responds just like 1 hour more in off time, the off time is more in the 1 day, I think the PTT, pallidothalamic tract lesioning, it will be improved the bradykinesia and rigidity. Yeah, PTT, pallidothalamic tract lesioning. Yeah, usually it can be improved the bradykinesia and rigidity.
Yes,
Okay.
but
Maybe like that.
I understand. Yes, but I think the unilateral PTT must be safe. But probably you cannot do the bilateral PTT.
Yes.
Yes. So
yes,
for the majority of the Parkinson's disease patients whose symptoms mainly in the akinetic rigidity type, they have bilateral symptoms on the bilateral rigidity of bradykinesia or dyskinesia. So the unilateral PTT may be not enough to control the whole body of the symptoms.
Yeah, we wait 1 hour, 1 year again, Prof. 1 year again, we do the
1 year apart,
part.
and you do a staged bilateral PTT.
Yeah. But we not yet start the bilateral PTT. Until now, we start bilateral PTT since maybe 2 years. Since 2 years. Before we do the GPI, bilateral GPI, subsequently bilateral GPI. But for PTT, maybe it is a good part for the more to avoid the adverse effect. Because for the bilateral GPI, although it is subsequently after 1 year, maybe it can make like Parkinson-like syndrome like that. Yeah, pseudobulbar palsy like that.
Yes. In my opinion, I want the audience to know that the bilateral regioning is very not safe, especially in Parkinson's disease patients, because the bilateral regioning surgery can induce the speech and the swallowing problems. That symptoms originally has confirmed in the Parkinson's disease preoperatively. So the essential tremor and the dystonia patients, they don't have any swallow and speech problems preoperatively. So the Parkinson's disease patients are very fragile to the bilateral regional surgery. So it's very difficult to consider which is the best for the patient. So we need to consider each one by one patient, what is the best for this patient to have a lesioning or DBS. Okay, so yes, any other comments from Hami?
No, I agree with you. It's bilateral lesioning usually sometimes dangerous. Sometimes we avoid to do that. Maybe we can do like the first surgery in PTT. Maybe in the 1 year after that we in GPI maybe different area. Different area will be safer.
Yeah, I agree. The stage the bilateral asymmetrical regioning may be better as in the simultaneous bilateral same structure regioning. Okay. So any other comments from the discussants? So
maybe Shahider, someone raise
okay,
hand.
Prof.
Yes, Prof.
Yes, please. I cannot confirm the
Shahid.
Shahid.
Yes, let me allow.
Dr. Raman,
Yes,
could you speak?
Can you hear me?
Yes.
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 Thank you, Dr. Fahmi, for your brilliant presentation. I wanted to know what is your success rate with lesioning and DBS, and how you manage if there is any infection after DBS.
The successful of the lesioning and DBS like that, Dr. Saidur.
Yes. I want to know the success rate with lesioning and DBS in your center, and how
Okay.
you manage if there is any infection after DBS.
Thank you very much, Dr. Saidur. It's very important question. Yeah, we start this surgery in our country in 2013. 2013 until now, it is about 10 years. And the most important thing is patient selection. Patient selection. If we choose the good patient candidate, it will be good result. But if we wrong to choose the patient, the result will be not good. That is very important. Number one, it is patient selection. Number two, it is accuracy and precision. We need to choose the location where we need to make a lesion. PTT or VRM or GPI or STN, yeah, like that. We need to choose and make it accurate. Yeah, make it accurate. And then the third one is the follow-up after surgery. Yeah, follow-up after surgery. Follow-up after surgery is mean the wound care, in the medication, and make the communication with the patient. Like Professor Risawa say that the Parkinson is very complex, not just movement. Yeah, still sometimes thinking, sometimes anxiety, sometimes depression. We need to manage that. That's all of the management for the Parkinson. Yeah, if we good at that, the successful will be very good. Yeah, very good. And then the second one, how about the DBS or lesioning? We more doing the lesioning in here. Yeah, we more doing lesioning. Just some patient of doing we perform DBS, but most of our case was lesioning. Yeah. And then how about the infection of DBS? We need to avoid that. Yeah, don't make an infection. But if we we don't have experience for infection for the DBS. Yeah, it is good. Yeah, still good. No experience of infection here. But we need to avoid like aseptic procedure, give like antibiotic for prophylaxis like that, and wound care after surgery. Yeah, maybe Horisawa Sensei maybe can adding about the infection in the DBS. How usually it need to take off the DBS. Maybe if it happen, we need to take off. But I have experience for perilid edema in the DBS. Be careful in the perilid edema. We frequently we not know about the perilid edema because after DBS, maybe 1 week after DBS, we didn't do any CT scan because the clinical is very good. But if we do CT scan, maybe there is a perilid edema because I have one patient with perilid edema and the patient unconscious, and then we give the medication and then the patient better again. Yeah, we not take off the DBS, but with medication the perilid edema will be good. Yeah, like that maybe.
Yes, and we need to distinguish from the infection and disease erosion, allergic infection to the device itself. So that if the infection, we only have to remove the device. I think the antibiotics must be useless for DBS infection. And the periodic edema is a very interesting topic in the current functional neurosurgery field. And the Japanese Thoracic Functional Neurosurgery Society, we just started to confirm the periodic edema just after the DBS surgery, and 1 week after or 1 month after. So, and some patients have a perilead cystic region around the DBS lead. Yes, and some patients, I have a very bad experience of the cerebral deep brain stimulation. That lead had the big cyst, and the patient had a headache and nausea, the vomiting. So we need to aspirate the perilead cyst. So we need to very take care of the post-operative lead around the lead condition 1 week after the surgery. And if the cyst or edema come out from the after the surgery, the steroid prescription may be useful to reduce the perilead edema. But I think the most of the perilead edema not problematic, so spontaneously improved with only observation. Okay, Dr. Rama, are you okay?
Thank you very much. Thank you.
Yes.
Okay.
Thank you, Dr.
Okay, any other comments? So
there is one question in the chat box. So by Dr. Hassan. So how long does a polydotomy with auric surgery takes usually? How long? How much time?
Yes, the procedure you mean, yeah? The procedure maybe, yeah? The procedure. Okay. Now the fastest, yeah, because the time for the surgery not too long, yeah, but the long time it is about the preparation before surgery. It's longer than the surgery, usually some like that, yeah. In the operating theater, maybe the fastest time that we in here, it is 35 minutes from skin to skin. 35, maybe in another center faster, but in our center the fastest is 35 minutes from skin to skin. But the important not that, but the preparation before the surgery, yeah. How we make the good target. Where is the target? Make a corrugation like that. It is very important. In the surgery room, it is just a few times, yeah, just not a long time, yeah. Maybe in here 35 minutes the fastest, until 1 hour maybe, like that. Thank you.
Okay, I think that's all for the questioning part, and maybe we shall proceed to the next talk due to the limit of time. So shall I invite the chair to introduce our next speakers?
Can I? Okay.
Yeah.
Please, thank you. Yes. Thank you very much, Dr. Fahmi, and let us move to another speaker. Dr. Petra, he let us to use his short name because of some difficulties in the pronunciation. He will talk about endoscopy. He's a doctor in University Hospital from Indonesia, Lipo village. He will present us the lecture dedicated to endoscopic spine surgery, from resource limited to resourceful settings. And so welcome, Dr. Petra. You may start.
Thank you very much, Dr. Alexander. So yes, my name is a little bit more difficult than your name. So I'm very happy with the short name as usual. So I'm Petra. I'm a young neurosurgeon from Jakarta, and I would like to share with you my presentation on endoscopic spine surgery. So this is a topic that I've been doing for about 3 years back. And the title of this presentation is coming because a lot of my newer graduates, they're talking about the future and so on and so forth. And we were thinking this kind of surgery is not yet frequently done in our country. And because a lot of my juniors, they're coming from very resource limited settings, you know, no microscopes, no high speed. And so we got this idea, let's talk about endoscopic spine and see how it can be applied to everyone. For example, for people in educational centers and also people in smaller hospitals. And let's see what we can do. Okay, so here's the slide. So why endoscopic spine? Because year by year, the evidence is becoming clear that it is proven to be useful for degenerative spine cases. A lot of papers came out and it can be used in limited settings, endoscopic assisted, of course, not purely endoscopic spine. And for resourceful surgeons, those with a big hospital and perhaps quite a big budget, we can go full endoscopic. And it's great for young neurosurgeons because a lot of people say that maybe for experienced neurosurgeons, it will be difficult because of the orientation is different and so on and so forth. So young people, let's go for it because we don't have a lot of experience. So it should be good to start a new thing. Okay. So as always, we are talking about change in focus from the usual open surgery to the minimal invasive surgery, a bit smaller paramedian approach, and then to endoscopic spine surgery, which is even smaller and even more targeted. On one hand, that is good because we are minimizing the trauma to the patient. On the other hand, it requires a separate school of thought, and I think better accuracy is needed to make sure we get the right pathology at the right time. Otherwise, we won't see it at all. And to discuss the breadth of it is not for this presentation. We will just be focusing on the endoscopic assisted and full endoscopic surgery, just a little bit of each that could be applied in all the different settings. So I was talking to my friends in the resource limited settings. That means that they don't have a microscope at all. And sometimes they don't have high-speed drills and so on. They have maybe their basic neurosurgical equipment. And we're saying, okay, so if a surgical microscope is not available, we're pretty sure endoscope towers are available because they're used by internal medicine, right? And by orthopedics everywhere. And so we just add a scope to the standard instrument set. For example, on the bottom right, you can see we can have some graspers, some keratins, some nerve hooks, and that should be enough to be added to a scope to perform endoscopically assisted surgery, which is actually not so different from microscopic or minimal invasive surgery. So the learning curve should not be very hard for young neurosurgeons. For example, what we're doing here is two techniques, the biportal and the Desh-Tandau techniques, and they use standard spine instruments with familiar views. And an added bonus is it's easier to insert the interbody cage through this technique compared to a full endoscopic surgery. Although it is more difficult to address foraminal pathologies using a posterior approach in the biportal or Desh-Tandau technique. So just for a standard comparison, the Desh-Tandau on the left side is mainly a dry technique. That means it's almost exactly like a microscope because it's dry. You don't use continuous irrigation. There will always be some blood blocking the way. Gravity is going to play a part. And most importantly, the fecal sac is going to be inflated with cerebrospinal fluid. And that is a very familiar view for all neurosurgeons. It's a single incision, 2 centimeters. On the bottom left, there is the Desh-Tandau set. And you can see that the working channel, the somewhat rectangular shape object, is very easy. And in some models, they can be converted
Hello, Petra.
Okay, something happened with the translation. So,
Yeah, I think Petra disconnected.
disconnected.
So
Something happened to the internet connection. So
Okay.
maybe let us wait for a minute. If not, we will
yeah,
ask
maybe we wait for a few minutes, and
Yes.
and I try to contact Petra, and if he does not respond, we proceed to next talk.
Yes. I suppose he has a problem with the internet. It's sometimes it happens. So, Professor Kato, how are my guys? A few words about our Ukrainian guys in your clinic.
Yes, they are working with understudy very hard. Every night they are doing the bypass, the training.
Good.
Yes, under the microscope. Yes. Unfortunately, just 3 weeks has passed very, very quickly, and they will leave the next week. That's 22nd.
Yeah.
But,
Unfortunately.
they explained so many things.
I'm preparing the next candidates. Is okay? Is it okay?
Yes, of course.
Are you
definitely.
agreed to accept them?
Yes,
Okay, I'm preparing the good.
Yeah, just I wanted to talk to you about that. Thank you.
Yes.
Welcome.
I have already some candidates, and I told with them, and we will start the process of sending. So
excellent.
Okay. Thank you.
Shall we ask Miniharu Sensei to talk how to think?
I already called Dr. Petra. He will join again. The connection is not good, Professor.
Okay.
Yes, sometimes it happens.
So maybe we can wait for him.
Yes, we'll just wait.
Sachin?
Hi, everyone. I'm fine, Professor.
Okay.
So since we have the time, I wanted to ask Achmat Fahmi a small question, and maybe Horisawa Sensei can also help. I have just assisted my chief, Dr. Balamurgan, in doing 2 deep brain stimulation surgery. So I'm not very expert of that, but I wanted to know what is the minimum age when you can do functional neurosurgery, and what kind of batteries do we have in the technology available in today's date? How long these batteries can survive? Because let's say we do it for some very young patient, and then how frequently he'll have to change those batteries? Dr. Achmat?
Thank you, Sachin. Yeah, this the battery life. We have now a rechargeable one. Maybe for one brand they have 15, but another brand they have 25. But another brand again, they told me that until 30 years maybe. But I don't know but in here it is 15 years. 15 years. The battery life. And the youngest patient for the DBS, I think we need to look the condition of the patient. Yeah, the condition. Maybe Horisawa Sensei can help to answer. I learned from him too. Thank you.
But I don't have so much experience of the pediatric patients, but DBS. But in Japan, probably 8 or 10 years old boy or girl can have the DBS due to the DYT1 dystonia. So I think it is feasible. And I'm not sure in detail, but in UK, 3 or 5 years old children with cerebral palsy have the deep brain stimulation to reduce the this hyperkinetic movements in London Children's Hospital. So I think the younger age is also a good candidate of the DBS, even in 3 to 5 years old. But I'm not sure, sorry, in detail of the procedure.
Thank you, Sensei.
Thank you. Thank you.
So what about the Petra?
Yeah, we don't see Petra yet.
Yeah.
And maybe shall we proceed with
Yes, I think
let's
so.
talk first.
Yes.
And
Yes.
Professor Famit, you have Petra's contact. Can you see, is there any problem with him? Maybe we proceed the let's talk first, and then we let him join in.
Yeah. The electricity in his place is shut down. The electricity. I call him. The electricity. He need to several minutes to join again.
Okay, then we proceed with the let's talk first,
Yes.
and then we go back to Petra.
Yeah.
Okay.
Yeah.
I
So,
think he's in the attendees list. Ben, can you promote him? I think he's in the attendees list. I can see his name.
Yeah, I can see him just now.
Yeah, so just promote him to panelist.
Yeah, just done.
This already here, Dr. Petra.
Yeah. I just promote him.
okay.
Oh, hello.
Hello, Petra.
Hello.
So sorry to take your
It's fine,
time.
it's fine.
Suddenly the
Yeah,
computer
it's okay.
shut down.
Okay.
So
No problem.
I joined with another computer.
It's-
Okay. Is it okay if I start the presentation?
Of course.
Yeah, sure.
Okay. So share screen and share window. Share. Okay. I believe it's up now.
Yes, we can.
Yes, go on.
Okay.
Go on, please.
All right. So sorry. I'll continue where I left off. I guess we talked about the beginning about how this idea came about for talking about the resource limited stuff. So did I go through a lot of slides before?
You have go to the one that you said you could. There are endoscope available in other specialties, and you can use.
Yes.
Yeah.
Of course. So okay, I'll go back about 3 or 4 slides then. Okay, so talking about endoscopes available in every center. So we can just use standard instruments and then add an endoscope, and we can perform some very basic stuff. Oh, it's moving around on its own. Okay. I'll just continue talking as we go along. So the presentation I was showing is about how the endoscope can be used with standard spine instruments without using a microscope, just using a C-arm, and that will be enough to do endoscopic spine surgery in a lot of centers. And we can, yes,
share your screen. We do not see. At least I do not see your screen. I can see only.
Oh yes, sir.
Only your first, please.
Okay. Can you see it?
Yes, it's okay. Please go on. I think you may start from this slide and then go on. Yes, okay, that's good.
Thank you very much. On the bottom right, we can see a standard set for the endoscopic surgery, which is very few instruments, and you can use this for a lot of things from canal decompression up to microdiscectomy with just these very few instruments in your center. And the view is very familiar with the endoscopic assisted surgery. Here we see 2 techniques, the biportal technique at the top and the Descendau technique at the bottom. So the main difference between that is that the Descendau is actually using only 1 portal. On the left side, you can see everything goes through that working channel. From the scope, the suction, the retractors, and then the instruments. So you handle actually 4 things at once. Your left hand controls the scope and the suction and the retractor, and your right hand will go with your carisons and your dissectors and so on. And so that's only a single incision. and it's dry, meaning you don't use continuous irrigation. In that way, it's very like a microscopic surgery. The thecal sac filled with cerebral fluid will always come up to the camera, and there will always be a little bit of blood blocking the view. And there is a learning curve mainly in handling the working channel and all the instruments in it, but otherwise it's very much like a standard microsurgical procedure. The biportal technique, on the other hand, as you can see on the right, is a wet technique. It always needs continuous water pressure to create a bubble for us to work in. It uses two incisions, smaller incisions, only as large as the scope. And on the bottom right, you can see the main advantage is that you can have an assistant. So you can have somebody holding the retractor, taking that thecal sac away from you. And it has an advantage on fusion. So it's very easy to actually clean and insert intervertebral disc space device inside. And the only learning curve is in making portal. So you have to make the two instruments meet at the end. So I'm told that's what orthopedic surgeons do every day, but it was quite difficult for me to handle. Now, we are actually doing a lot more Destandau in a lot of our friends' hospital, because it uses no water, because usually use 20 to 30 liters, sometimes 40 liters of saline to actually create the working field in a biportal technique, and that's actually additional cost. So Destandau technique is less cost. And in this 1 minute video, we can see how a biportal method can very efficiently clean the bone, uses a standard high-speed drill to take out the lamina, and we can identify the yellow ligament very nicely, and we can take it out with using standard instruments such as the 3mm Kerrisons. There is less risk of a dural rupture using the biportal technique, because the water actually pushes that thecal sac away from you. So the moment you create a small opening on the yellow ligament, you're actually pretty much safe, because the dural sac is being taken away. And here we see we are using annuloplasty technique to actually reduce the herniated disc without making a hole on the annulus. This is mostly recommended for canal stenosis patients. That means that older patients with very hypertrophied ligamentum flavum, and perhaps the bulging disc is not so problematic in this patient. Now, in resourceful settings where you have a lot of things available, you can choose your instrument sets. And this is very important, because the advantage of addressing each pathology is that you can be more precise, you can minimize the trauma to the patient, and you can have the best view. As you can see on the right side, we have many choices of approaches. And on the left side, we can see a lot of different scopes, different lengths, different diameters. And this is just from one brand. We're talking about many, many other brands available. So if you have actually a lot of funds available, you can take several options, and you can go from a translaminar or a transforaminal route. So the targeting is very important, because it's playing by itself again. I'm very sorry. So the targeting is very important, because if you miss the target,
please share the slide again. Is just
oh yes, I'm trying. I'm just doing it while talking a bit. So if you are off with the targeting, okay, you can't actually see what you're working with. So here we see if we want to go from the lateral side, we can have the red, green, and yellow dots highlighted. We can go from a transforaminal route. But we will have problems if you see the middle picture with the spinous process. You can only go to the bottom yellow dot. If you go up to the second yellow dot, you'll have to resect a lot of bone. and it's very dangerous to drill. It's quite dangerous to use the rongeurs in a limited space. So with a transforaminal route, it's very complicated, and you should have a lot of resources to do it. See, oh, sorry, here we go. Transforaminal route. If we resect a lot, we can actually go contralaterally from the side. But for the standard translaminar route, we can address the yellow and purple dots very easily, but you can't see anything on the green or red side. So the patient selection at the beginning has to be precise, or you can't actually see what you're working with here. And a quote from Dr. Girish Datar that there is actually a lot of thought before you decide which way you want to go, from the transforaminal or the side. So for interlaminar surgery, we can do standard discs as shown in this picture. Okay. It's very easy to actually take out the disc fragment in this manner. It's very quick too. It uses only about 20 minutes to reach this space to take out the disc fragment. And the rest of the time, you just need to control the bleeding and take out the other fragments from inside the annulus. The whole operation will take only about 40 minutes, and it's quite satisfactory because the wound is also very small. You can see the instruments are very familiar to us, standard graspers, standard Harrisons, everything is as it should be. The only difference is the viewpoint from the endoscope. And this is an example of transforaminal surgery. We're going in from the side here. This is very useful for pathologies such as internal disc disease, where there is not a very big hole in the annulus. You can see at the very middle of the annulus, there is a small hole. And we can do this with minimal trauma to the patient. And this kind of views we actually never see in our training, because this is the inside the annulus from the side, and you cannot get this view from a microscope. So there is a significant learning curve needed here. Okay, so in our center, this is the data from last January. Now we have up to about 80 patients. And mostly is done from an interlaminar method, because mostly the pathology is canal stenosis. So we take out a bit of the lamina, and we take out the yellow ligament, and we do some discoplasty, and that's all. For the herniated disc, it's mostly younger patients, and all we do is just take out the fragment and do some annuloplasty, and that's good. Of note is because for us, this is quite a new technique. We have a lot of complications, actually. We have quite a few dural tears, although none of them progresses to be a problem in the future. We just put some gel foam on it, and that's that. Some recurrence of the herniated disc, and up to 3 reoperations because of the recurrent herniated discs. Most of the patients have temporary hip aesthesia. In the literature, it's caused by the increased water pressure as we are doing the operation. And one patient has a motoric weakness and loss of micturition control for a temporary method. So in conclusion, the endoscopic spine, it can be done in many settings where microscopes are not available. And as young neurosurgeons, I think we should be able to step out of our comfort zone. Big learning curve is expected, but there's a lot of room for improvements, and it's very satisfactory, especially for the high risk patients. We have 0 infections, even though a lot of our patients are on anticoagulants, have diabetes, and so on and so forth. So it's very suitable for high risk patients. A disclaimer though, because I am a young neurosurgeon and I've not been up to 100 cases. So perhaps my confidence is pretty high because my experience isn't so much. And I hope we can do a lot more of these surgeries in the future, and perhaps we can persuade other people to join us so we can expand endoscopic spine surgery. Thank you very much for your time. I'm sorry for the technical problems. I hope it's a good presentation for you.
Thank you, Petra.
Thank-
And Professor Olesen, please kindly comment.
Yes, thank you, Dr. Petra. Thank you for very good, informative, and really honest presentation. It's very good that really you build up your presentation in a way that you didn't try to insist that endoscopy is better than conventional surgery, so on, so on. So thank you for this normal approach to the problem. Because really, there's in modern spine neurosurgery, there is the interesting process is going on. The skilled neurosurgeons who do effective microsurgical neurosurgery, they proceed doing this quite effectively and go on and doing, and not all of them I want to start training in endoscopy, because they are satisfied, their patients are satisfied, and that is why they are not so interesting in endoscopic way. For instance, from other hand, neurosurgeons like you, the new generation, you are enthusiastic, you are starting to proceed with the new technologies, and thank you for this. You develop it, of course. So this technology require the learning curve time, and I think according to results you presented, another also thank you very much for your honest result. You showed your complications because you are really somewhere, I suppose, at the end of your learning curve term. So I think the next group, next series of your surgery will be much better, and you will go on and you will proceed, because I believe, I know that anyway in the future we will come to endoscopic neurosurgery, not only in spine surgery in majority of cases. So that is why I want to thank you and want to wish you a big progress in your working, and hope to see you personally somewhere. So, okay, thank you.
Okay, Professor Olesen, so maybe because of time, shall we move to the next talk?
Okay, let us move
Yes.
to the.
Oh, sorry, Fahmi, you have some comments?
Thank you very much. I have a question for Dr. Petra. Dr. Petra, for the endoscopy that you perform, it is in awake or in the general anesthesia? What do you think with the awake and general anesthesia in the endoscopic like that? I know there's some of the neurosurgeon doing the like awake, but another doing with the general anesthesia. Thank you.
Thank you so much, Dr. Fahmi. So in our center, if I can be honest, everything we started asleep with neuro monitoring because we were afraid of complications and they're awake to hear it. But after the first few cases, we are confident enough to do awake surgery, especially the transforaminal surgery coming from the side. It's very important for the patient to be awake so we don't hit the nerve root by mistake. However, if we come from the back, from the interlaminar method, we find that with the patient awake, the blood pressure is less controllable. And this can make a lot of bleeding. And it's a very big problem for us, especially. So we decided to do our transforaminal surgeries awake and our translaminar surgeries asleep. Because coming from the back, there is also less chance of hitting the nerve root. So it's quite as safe as a standard procedure in sleep. So thank you very much for your question.
Thank you, Dr. Petra.
Okay, we're moving on.
Yes.
Let us go to the next speaker.
Yes.
Yeah, let me present our last speaker, Professor Yohei Mineharu, professor from Department of Neurosurgery and Department of Artificial Intelligence in Healthcare of Medicine from Kyoto University Graduate School of Medicine, Kyoto, Japan. So Professor Mineharu, you can start with the talk about the neurophysiological monitoring and the awake craniotomy. So please.
Thank you for giving me a great opportunity, and thank you, Professor Wozniak. I'm Yohei Mineharu from Kyoto University. Mineharu is a little bit difficult to remember, and please remind me as a mineral water. I'd like to today to talk about the neurophysiological monitoring awake craniotomy. This is my UI. And this is non-enhancing tumor which infiltrated into the coronal radiator. This is a big tumor in the language area. This is a tumor in the buttocks. These are all a little bit difficult to treat. How do you treat these patients? The most important thing is a maximum safe resection without neurological deficit. And to improve the outcome patient, we need to minimize the stress of the surgeons ourselves. And to minimize the stress, the visualization is very important. For this purpose, the awake craniotomy and neurophysical monitoring and combined with navigation is very efficient. And I'd like to talk about these two topics. And in addition to that, I'd like to talk briefly about the exoscope surgery, which can also reduce our stress. And as for awake craniotomy, the history of awake craniotomy is relatively long. In 1886, Victory Jose done the surgery with cortical stimulation. And in 1950, switching from general anesthesia to local anesthesia could become possible with using codeine. And in 1960s, NLA was developed. And in 1990s, thanks to the infusion anesthesia called propofol, we can do without stress for the awake craniotomy for brain tumor surgery. This is an example of the awake craniotomy in 1996. There are several types of awake craniotomy. The typical example is asleep, awake, and asleep craniotomy. According to the national survey in Japan, most of the facility adopted this one. And another option would be the general anesthesia, awake, and after that, monitors anesthesia with just a sedation without intubation. We are adopting this one, but the relatively small number of facilities use this technique. And this is advantageous because we don't need to care about the intubation again. And the pre-awake phase, usually the anesthesia consists of three components: sedation, analgesia, and immobilization. But for awake phase, the immobilization, we don't need it. And for sedation, we are using propofol and using the control of the TCI around 2 to 4 micrograms per ml. And for analgesia, the remifentanil is very effective, and we also use local anesthesia. And the advantage of the propofol is a minimum emergent excitement and secure airway management and the minimum impact on evoked potential, because we adopt physiological monitoring, so it is very important that sedative don't affect the evoked potentials. And the propofol also has anti-emetic properties and anti-epileptic property, which is important for the brain tumor surgery. And the propofol should be controlled by TCI, target control infusion. And this is based on the pharmacokinetic model. And so we need to input target concentration, but not the infusion volume or speed. And the computer can automatically calculate the ideal TCI. This is an example of the iPhone application. The volume is different from the TCI. And this monitoring is also effective. And in awake craniotomy, we often make a flap of the forehead. So it is sometimes difficult to put this monitoring on the forehead. So at that time, we usually put this monitoring on the nose. And this is an example. Yeah, we put this monitoring on the nose, and we monitor the CO2 using this apparatus. And we also use the hand grip at the monitoring of the consciousness. I will talk about this later. And we also use dexamethasone because due to minimum respiratory distraction. But because of a long half-life, we have to pay attention to the infusion rate. And as for analgesics, remifentanil is very effective because it is a very short half-life. So, but in the awake phase, we usually use low dose remifentanil to suppress the patient pain. But recently, we found that remifentanil is not so effective in the as an analgesic in the awake phase. And because of the side effect of nausea, we recently reduced the usage of remifentanil in the awake phase. But it's okay for the pre-awake phase, it is very effective. As for pain control, scalp nerve block is critically important. But we have to be very careful for the drug overdosage. If we inject more than 40 ml, the patient will experience epileptic attacks. So we have to be very careful. We will use usually inject lepivocaine and lidocaine and 1:1 concentration and upper margin of the eyebrow and outside of the orbital rim, and 1.5 centimeter anterior to the tragus, and 1.5 centimeter posterior to auricle, and between occipital protuberance and mastoid process. This is very critical for the successful awake craniotomy. As for the awake airway management, most of the facility use this laryngeal mask called iGel or ProSeal. ProSeal is very solid and stable, but this is a coiled tube, so this is not MRI incompatible. So if we want to use intraoperative MRI, this is not suitable for that. And iGel, there is no coil and no cuff, so it is very easy to handle. And as for intraoperative seizure, the most important thing is the cooling of the brain with the iced artificial CSF or saline. And if this is not effective, we sometimes use propofol or phenytoin, but in most cases, cooling should be enough. As for prevention of nausea, the dexamethasone is very effective. In our facility, we haven't used for the dexamethasone, but as compared to before induction, after induction, the nausea and vomiting decrease very dramatically. So we usually use dexamethasone. And as for neurophysical monitoring, and monitoring of arousal is important because we need to know whether the patient can respond to our request. And as compared to GCS, Japanese coma scale GCS is very convenient because we can discriminate the relatively, not fully, but a relatively conscious condition. One digit code is a patient is awake, but a little bit not fully conscious. JCS1 means almost fully conscious. 2 is unable to recognize time, place of person. And 3 is unable to recall name or date of birth. And 10 is just respond after simulation. And as I showed before, we use hand strength to know the patient consciousness. Because this is a Japan coma scale. According to the arousal become improved, the hand strength become larger. And as compared to BIS, the hand grip strength is well correlated with coma scale. And this is compatible with propofol. So the hand strength is a very good indicator for consciousness. As compared to BIS, and hand strength in the unaffected side is better to predict good consciousness. This is almost compatible with propofol concentration. So the hand grip is very easy to take. So we routinely use hand strength to determine the patient is fully awake. At a level we can perform awake craniotomy and monitoring. As for monitoring, and the knowing the position of the fiber is also very important. And in the advanced technique, we can easily visualize the fiber cortex or the important structures. And not only the stimulation of the cortex, but also the knowing the position of the fiber is very important. And we use cortical evoked potential called Sept. And the fundamental concept of this Sept is a stimulation on the one side and receive the potential, evoked potential on the other side. Then we can know the connection between them. We can detect a very short latent wave. And this indicates the connection between the Broca area and the Wernicke area. If we stimulate the Broca area, we can detect these kind of waves in the Wernicke area. And if we damage the fiber between them, the potential will decrease. We can know whether we can continue aspirating the tumor or not. And we also use the fiber stimulation, and we can identify how far the nerve fiber is. So these techniques can very use even in the not only awake phase but also asleep phase. So these techniques can weaken the stress of the neurosurgeons. And lastly, we want to talk about the exoscope briefly. There are various types of exoscope, and the 3D Bidom is based on the endoscope, and the Kinebo is basically this is microscope that we can use as an exoscope. And this is the recently developed mostly conveniently handled with a video-based exoscope. And this is a OI, and it is like a video, and it is very easy to handle with. And using the foot switch, they can automatically move like this. And we don't need to touch this microscope, and we can control very easily like this. And with microscope, we sometimes have to take this very difficult posture like this. But after using the OI, we don't need to take this difficult posture. And in addition to that, the advantage of the OI is it's like a combination of lupe and microscope. And we can switch easily from lupe to microscope. And as I said before, by using the foot switch, we don't need to release our hands and continue the surgery. And the visualization of the small artery is also very good. And another advantage is good visualization of 5LA. As compared to the other one, the microscope, we can easily detect the fluorescence of 5LA. Another example of the when we monitor the nerve fibers, and we know that we are very close to the nerve fibers, we can slowly aspirate this. And if we use OBI, we can detect the edge between the tumor and the normal brain. And OBI is very good for the real-time guidance, and so it's good for education. We can share the same visual field as a main operator. So the awake craniotomy and neurophysiological monitoring and endoscope can minimize our stress, and that can improve the outcome of patient. Thank you for your attention.
So, Dr. Ben?
Yes, Professor Allison, please carry chair the discussion.
Yes. Professor Minoharu, thank you. Thank you very much for a great lecture. A great, very interesting lecture. I absolutely agree with you that modern neurosurgery is impossible without neurophysiological monitoring at any level, from the simple cortical lesions to complex skull-based lesions. I have some questions concerning your talk. First of all, do you have a protocol for selection of the patient for awake craniotomy? Because you know that not all the candidates could be awakened during surgery. There are some restrictions and limitations. What kind of protocol do you use for this?
Yes, thank you for the question. And yeah, we have some protocol to determine whether we should include a patient in awake craniotomy. And usually the age and the size of the tumor, if the tumor is too big, and then it can cause herniation, so we cannot use awake craniotomy because we cannot control the ventilation. So if we want to do awake craniotomy for the patient who have big tumor, we will use second stage surgery. We will resect the reduce the volume of the tumor, and after that we will operate using the awake craniotomy.
Okay, thank you. And some more questions. First of all, do you use a functional MRI before surgery? Do you rely on dominant or non-dominant hemisphere when you plan the awake craniotomy? And what functions do you control? Do you control some extra functional beside the movement and speech and calculating? Calculations.
Yeah, ideally we should take care of not only the speech and the motor, but also the other higher functions. But unfortunately, we don't have enough human resources to perform that kind of detailed examination. But
Yes.
Other some facilities, they are also working on that. For example, how to play for the guitarist, how to whether they can keep
yes
doing that.
Mm.
Yeah.
Yes. And I asked about the dominant, non-dominant. Do you rely on, or you do awake in spite of left or right side?
And mainly we perform the awake craniotomy for the dominant side, but sometimes we do the non-dominant side, because CEP or some evoked potential is we can detect more clearly in awake phase. So sometimes we use to make the evoked potential clearly. We use even in the non-dominant side.
Okay, thank you. My comment is that I want to remind you that publication of Professor Dufault from France. He reported a very big series, and he compared the glioma surgery with the open craniotomy and without open craniotomy, and so he showed that awake craniotomy is feasible for any kind of surgery performed on the functionally important zone. It doesn't matter it's dominant or it's not dominant hemisphere, because the speech presentation in the cortex is more complex than we used to know from classic neurology. That's one. And I especially asked a question about some additional function control, like emotion, like so on, so on. It's really interesting. Maybe it's good for science, but for me, for a neurosurgeon, if I can remove tumor from the right frontal lobe, which extends to the closer to the subcortical part, and suddenly neurophysiology will say me that patients probably may be depressed after surgery if you would remove this part of the tumor. So I'm sorry, I'm neurosurgeon, and I will go on. And I think that we will manage the depression with psychologists or psychiatrists after surgery much, and I think it's much better for the patient in terms of his survival, recurrence-free time, and the radicality of the surgery. So this is my option concerning some emotional control of emotional sphere during awaked craniotomy. And so thank you very much. Maybe someone has some more questions.
Yes, can I ask a question? And just a quick question. So in your center, usually what neuropsychological tests you use to map the SMA and also the IFOF?
Yes. And I agree. It's interesting. It's scientifically very interesting, but in practice, sometimes it wouldn't stop me as a neurosurgeon. Maybe only in case of some legal problem after surgery. So I will stop. Because so
what kind
it's my position. Yes.
So usually, Professor, what kind of test you use for these two areas? I just wonder, what kind of neuropsychology?
In my clinic we do not use neuropsychological. I just know it from publications, from reports in different congresses. So we even didn't start. And also we have the same problem with the resources. I have only one doctor on neuromonitoring, and that's all. He's a neurologist and neuro. So I cannot attract another team of psychologists for this job, and do not plan to do it in nearest future.
Understand. And also, I can see Dr. Sorry, Professor Yuhi, you want to give some?
To perform the emotional test, we have to develop a specific task to monitor the emotional changes, but that's very difficult. So we are now developing.
I agree with you. I agree.
Okay.
Just I want to ask Mineharu Sensei. Thank you very much for excellent talk. So just I want to ask because exoscope is in the future is a replace of the microscope. How do you think of that?
I think it can be replaced by microscope.
Replace.
Cheaper, and it can be distributed worldwide. It can reduce the stress of the surgeons. So but it takes a little bit of time to improve the visualization, the very small architectures. So there should be. Currently, it's impossible to totally replace microscope. But in the future, I think it's possible.
Thank you so much. Thank you. Wonderful, the operation theater. Thank you so much.
Thank you so much.
Okay, maybe because of time, we have a last question from Dr. Dilshad. Dilshad, you want to raise a question?
Yes, thank you so much, Dr. Mineharu, for excellent talk about awake craniotomy and prospective directions. Joining the exoscope, and it's very deserves appreciation regarding its availability and many advantages. My question is about the test to analyze the handedness. Do you use some kind of test to assess the handedness of the patients, like Edinburgh inventory test?
Yes, that's right. Edinburgh, yeah.
Okay, thank you so much.
And we also see the functional MRI, which can give us a hint.
Okay, Thank you so much.
Okay, and thank you so much. Maybe because of time, Professor Kato, shall we run this session and then we proceed to the Fujita alumni webinar in a
Yes, from 7 p.m.
yes.
Thank you very much for all three speakers. It was wonderful. The mandate today is the functional, and also the Petra, the endoscope is the current, very getting popular, the instruments. And also, Minihao Sensei showed us very modern, but the ABEC surgery is, I think, extreme, the minimally invasive for the patient. I think is a great lectures. Thank you very much. And also the Bosniak, thank you very much for you send me so many, the two good, the young doctors. Right now they are working so hard every day. And also, Orisa Sensei, thank you very much for support many times for ACNS. Thank you so much.
Thank you. And thank you for invitation. Thank you.
Thank you very much. Okay, Ben.
So thank you so much to all of the audience. So it's a bye-bye to all of us, and we look forward to see you in the next ACNS webinars. So we also have Fujita alumni webinars for the coming session. So maybe we end this session, and I hope to see you all in the next webinar. Thank you so much for all of you.
Thank you very much, Prof.